McManus, can you guys hear us?
We can hear you.
Okay. Mary's going to introduce herself.
I am Mary McManus, one of the inpatient diabetes educators.
And we have been graciously asked to do a presentation for Children's Hospital for the residents on the diabetes education process. We're happy to share information with you today. So our objectives, we're going to be looking at some of the differences between type 1, type 2 MODY, and LADA, looking at the treatment options, and then looking at what are primary inpatient concerns for diabetes management and education, and what are some of the outpatient concerns that we see and encounter for our kids. With children with diabetes, the child and the family, they are the center of our care. And as you all know, medical management is critical, and nutrition therapy plays a key role in any issue of glycemic management, as well as the education itself. And psychosocial factors are a major part of the education process with our kids. At Prisma Health Children's Hospital in the Midlands, Children's Health is one of the first children's hospital for South Carolina, and it serves more than 150,000 children and their families each year with 30 subspecialties, as well as a specialized children's emergency department. Just to give you a little statistics, for diabetes education, for fiscal year 20, which is October 19th through September 20th, we have seen 64 new onset type 1s, 37 new onset type 2s, 8 others, which includes from neonatal diabetes to some secondary diabetes. And we have seen 155 children with repeat visits. So that's a total of 264 patients seen for Children's Hospital. The year before, in 2019, we saw 273. And our total new children seen for 2020 was 107. And of those repeat visits, of the 155, we found that 25 children counted for 75 of those total 155 repeat visits. So with type 1, as you know, it's an autoimmune disease, it's chronic. Different factors influence type 1, including genetics. And we feel like viruses are the major contributors to type 1. When we're dealing with children with type 1, we have to think about things such as insulin sensitivity, their physical growth and development, their sexual maturation, their ability to provide self-care and the supervision in the child care or the school setting, as well as their neurological vulnerability to hypo and hyperglycemia. Some of the rationale for managing kids with diabetes with the control that we do, one was the Diabetes Control and Complications Trial. This was a randomized study that showed that people with type 1 who kept the blood glucose level as normal as possible reap benefits in terms of decreased complications with eye disease, kidney disease, and nerve disease. The other major study is the EPIC, or Epidemiology of Diabetes Intervention and Complications. And they looked at, in this study, eye disease, kidney disease, nerve problems, and cardiovascular disease like heart attack and stroke. and it was able to show that with intensive blood glucose management that there was a lower reduction in these factors. Related studies, the UK-PDS study showed that controlling glucose levels in people with type 2 helped with eye disease and kidney disease. A core study was more on adults. And the big thing with a core study was that this is where practitioners started backing down on some of the intensive treatment because they were fearful of hypoglycemia. And the Search for Diabetes in Youth study found that rates of new diagnosed cases of type 1 and type 2 is increasing in youths in the United States. But the interesting thing about this was they found that in teens with type 2 diabetes, that they were more readily to develop problems with kidney disease, eye disease, and some risk factors for heart disease. And we're seeing this with in Children's Hospital that a lot of our new type 2s, they already have problems with blood pressure, with their kidneys, cholesterol, and other issues. With type 2, it's usually more insulin resistance, and we see that the pancreas either isn't making enough insulin, doesn't release insulin at the proper time in relation to the meals, or the cells are resistant to the uptake of insulin. And we just wanted to just share some information with MODY. Most of our practitioners in the academic setting have heard of these, but this is mature onset diabetes of youth, and this is sort of unfamiliar territory for most of our adult practitioners. There's actually 11 different types of MODY, and this is an inherited autosomal dominant pattern. It accounts for about 1 to 2% of the individuals that have type 2 diabetes. And the big thing about MODY is that it's a monogenic gene mutation. And there's usually 3 main classifications. The 3 main features is that people usually develop it before they reach age 25. It usually runs in consecutive generations of a family, and it's the treatment can vary. And some of the interesting things that they found about mature onset diabetes of youth is that with MODY-2, usually eating right and exercising or lifestyle is all that's required. With MODY-1, 3, and 4, those 3 categories are usually managed with a sulfonylurea. MODY-5 usually has a variety of treatment, and the newest is MODY-7 through 11. They just recently discovered that, and they're learning the treatment options with this particular type. So this slide is not to, it sort of like reiterates what we just said, but basically to show you that it is a monogenic type of diabetes, and it does run in families. The second type that is popular is the latent autoimmune diabetes in adults, and this sort of has characteristics of type 2 as well as type 1 diabetes. Usually the predominant that we see is that it is autoimmune like type 1, but people usually have lower BMIs. So a visualization of the overlap you can see in type 1 diabetes in children and type 1 diabetes in adults, that immunity is strong, so HLA is positive, and the BMI is usually low or normal, and insulin is required. With LATA, the immunity is a little bit weaker, but it's still autoimmune to some extent, and with type 2, it's sort of like the opposite of those. And LATA is also known as type 1.5 diabetes. Neonatal diabetes, we do see this from time to time. Dr. Lisa Knight is sort of like our resident expert on neonatal diabetes. It's a disease that affects infants in the first 6 months of life. The major treatment is usually oral sulfonylureas, but sometimes these babies do require insulin. The big challenge with insulin is that just trying to get it in a lower enough concentration for them that it's safe and effective. So when we look at medications, insulin is our primary for both most of our children with type 1 and type 2. Metformin, a biguanide that helps prevent overproduction of glucose from the liver and improves the body's sensitivity towards insulin uptake, is used for type 2. Our GLP-1 agonist, we don't see a lot of this in Children's Hospital, but this is a category of drugs that do four things. They tell your brain that you're full. They slow food movement through the GI tract. They slow production of glucose from the liver, and they tell your pancreas to only secrete insulin when your blood sugars are high. Well, obesity is a big problem with type 2 diabetes, and it's been used effectively in adults. And recently, the FDA approved Victoza for type 2 diabetes in children ages 10 through 17. And we already talked about sulfonylureas being a major treatment option for neonatal diabetes and in MODY subset 1, 3, and 4. Basal insulins, this is our background long-acting insulin. Our intermediate NPH usually works for 12 hours, so they usually get that twice a day, long-acting 24 hours. The big thing is when kids, particularly our type 1, skip their basal, they usually end up in DKA. And the other thing from a PICU standpoint, usually we need some type of sub-Q insulin, preferably basal on board before insulin is transitioned. And this usually happens really good in Children's Hospital. They usually even give the basal the evening before the drip is ready to be discontinued. Rapid-acting insulin, this insulin is used to cover meals, which is the prandial, our bolus dose, and correction. The big thing about rapid-acting insulin is that it really starts lowering blood sugars within 15 minutes, and it can really contribute to hypoglycemia if kids are not eating effectively. Metformin is one of the initial treatments for type 2. A lot of our kids do come in with type 2 diabetes also benefiting from metformin. So one of the guidelines from the ADA is they recommend that you continue to add other medicines or intensify treatment in addition to metformin in these children that have the insulin resistance. The ADA has set a hemoglobin A1C target of 7.5% for all children with their age groups. They used to have varying for less than 6, etc. But the glucose targets do vary. So you can see them listed here. So the smaller the child, we go from 80 to 200, less than 6. The older the child, we go up to 70 to 150. So they more closely resemble adults. If you guys have any questions at any time, please let us know. And insulin pumps and sensors, they can be continued in the hospital setting, and they should have a provider order, and somewhere in the chart it should be documented what the actual rate the child is receiving. And for children to continue pumps in the hospital, either the child, but preferably the parent or guardian, should be at the bedside and able to help with the management of the pump and the continuous glucose monitor. When we look at children in terms of education, it is very important to approach them based on their developmental stage. When we're looking at babies, we're in the infancy with trust versus mistrust, and we have to be very cognizant of how we, interact with them, try to keep them in the parent's arm. If they have any kind of blankets or security animals, keep that with them. Early childhood, they're in autonomy versus shame and doubt. And this is where they're learning to talk, walk, potty train. And we just want to make sure that they have a good self image. Preschool, we want to involve them. This is where we really start, trying to, use some play therapy and letting them touch pens, touch meters, and to the extent possible, so that they are more accepting. The school age industry that also continues with the from our tactics from the preschool. They can be more involved. We have 6 and 7-year-olds that are highly involved and want to do their own blood sugars, but they just can't be responsible for that. And that is one of the big things that we stress all throughout is that an adult has to be responsible for the care and management of the children. Adolescent, there's a lot of problems with identity versus role confusion. Socialization is a big issue of concern during this phase, and we also know rebellion. And Mary's going to go from here.
Nutrition, it's very important that we individualize it for the family. Our type 1s and our type 2, we kind of approach them differently with carb recommendations. And nutrition must be ongoing. I meet some families that do not like vegetables or don't know what vegetables are. And so I encourage them to guide them towards healthy eating as they continue to grow. It's important that we get a nutritional consult put in, and that's under consult nutrition, and be sure to hit the pediatric one. It's important that we kind of individualize our care too, based on how our families are. It's imperative that we have a caregiver, a responsible caregiver that can take care of the children. We try to assess for their educational needs and behavior, emotional, psychosocial factors, and implement a treatment plan based on those things. COVID has hampered our ability to teach the family like we would want to. Not every family has 2 parents in it. Sometimes you have a single parent who depends on a grandparent to help her, and getting those people in the hospital for education right now can be troublesome. We also need to meet these families where they're at. We have a lot of patients that are going through life-changing events, especially right now with everything that's going on in our world. Also, with foster parents, it takes a little while to find a foster family, and we even have had to go and teach the healthcare providers at some of the group homes that they go into. Like Connie alluded to, it's important that our children are supervised, and they spend a large portion of their time at school. It's important that we encourage the family to have good communications with the nurses. Some of our nurses are absolutely fantastic in that they will even agree to give the long-acting insulin so that we can guarantee that some of our children are even getting them 5 days a week. And so parents are encouraged to reach out to the nurse In middle school, children are expected to come to the nurse to be checked without being prompted. And I encourage the parents, if the child misses too many coming by, for them to contact them. The school also provides a 504 plan, which will basically, the parents can ask the school to do special things like allow them to make up when they miss a test or something like that. Physical activity. It's important that all children get 60 minutes of exercise daily. This is strongly encouraged with all the children, but especially with our children with type 2. We also want to monitor our children with diabetes, let them know that exercise lowers blood sugar. We have to teach strategies to prevent hypo, like checking the blood sugar before the activity to see where they're at. It may also include having a snack with carbs and protein prior to the exercise, depending on where their blood sugar is. We teach the rule of 15 for hypoglycemia. We want them to get 15 grams of fast-acting carbs and then recheck again in 15 minutes. Teach the signs and symptoms of hypo. Some of them are fortunate enough to have that feeling before they leave the hospital, and we can make adjustments as needed. But it also, we reassure the family, see, we handled that, here's how we handled it, and it can be handled. The other thing, whenever we're looking at exercise, we encourage the parents, like if the child's starting soccer practice or basketball for the season, that the parents monitor how that exercise is affecting its blood sugar, and that it can be affected up to 6 hours and later, and so maybe re-implementing the 2 a.m. blood sugar check so that they can see what they're doing at night. These are, the glucagon needs to be ordered on every child at risk for having hypoglycemia. We do this with our pediatric population. It's important that the parents teach all the caregivers, and especially the ones at school. And I've heard from students that a lot of the coaches and people know how to use the glucagon kit, Gvoke is new. It's more like an EpiPen. It does not have to be mixed, taking away that step for a parent who is in a crisis situation. The other is Baqsimi. It is an inhaled glucagon, and the inhaled is approved for children 4 and up, and the Gvoke is approved for children 2 and up. Just keeping that in mind. Most students need 2, 1 for school and 1 for home.
Okay. This is Connie, and I'm switching to psychosocial issues. We want to make sure that, no, that's supposed to be good. I'm sorry.
Excuse us, y'all. We want, with our psychosocial issues, we want to encourage case management, social worker, psychiatry, counseling, support groups. JDRF is a great support group. I strongly encourage the families to kind of check out their website and see. They also offer mentors. So with some of these children that are coming back in that Connie spoke of earlier, we might can hook them up with a mentor that might could help in some way reach them. The other thing is camp. Camp is wonderful, where a child can go and be a kid for a day. The other concerns we have are eating disorders. We do have children with type 1 diabetes that do we call it diabulimia. They are overweight, they want to fit into a prom dress, they miss their insulin to lose weight, to go into DKA. Unfortunately, a lot of times it lands them at the hospital. Signs of this might be over-exercising, feeling fat, preoccupied with it, abnormal electrolytes, large intakes of food, and anxiety around food in general. The other psychological issues is ADHD. I can always tell when these children are feeling better because they start climbing the walls when I'm trying to teach their parents. But we need to take this into consideration. These children are not going to remember to get their medicine. They're going to have parents and caregivers involved. Depression is very real. It is linked to most diabetes. Lack of supervision. A person needs to realize that our children cannot be responsible for their diabetes.
Okay. So this is Connie, and DKA, we are very familiar with the pathogenesis and the hallmark. High blood sugar, the ketosis, the electrolyte derangement, the dehydration, and Children's Hospital does an excellent job in managing and using the 3-bag method, which also includes dextrose. One of the providers at Medical University of South Carolina said that she equated every time one of her kids coming in with DKA with them having like a post-concussion syndrome. And they followed these kids over time, and they have like neurological deficits, that they have decline in their academic performance. So it is a major concern. We ask parents and kids to check ketones for blood sugar 240 or higher, and to implement their sick day plan. Please remember that as kids get older, they outgrow their formulas. And so we also see an increased need for insulin during female with menstrual cycles. And we teach them how to use their correction formula, how to increase non-caloric beverages to try to combat that dehydration so that they don't have to come in the hospital. Question or comment? Okay. We also see in type 1 a correlation with a lot of other autoimmune conditions. The two most common would be celiac, which is immune related, and thyroid disorders. With celiac, they recommend that you check for it at diagnosis and repeat every 2 to 5 years, particularly when there's poor growth, an increase in hypoglycemia, low blood sugar episodes. For thyroid disease, the recommendation is that you check at diagnosis and every 1 to 2 years if the person's normal and stable. For finances, this is a major concern because diabetes management is not cheap, and you have to tailor prescriptions and medications to that covered by the patient's insurance. So pharmacy is crucial, and and you guys do a good job getting concierge available, to the room before discharge. And if they're uninsured, like Mary said, make sure we consult case management. Prior authorization might be needed for certain medications or equipment. We need to make sure that for patients that we match their meds to what's covered. For chronic noncompliance, most people don't like mixed insulins, but sometimes it's appropriate, or if the parent or the family is not medically sophisticated, they don't have a high reading level or comprehension. And Mary already spoke about glucagon being ordered.
In the binder that we give our patients, we do try to offer some resources, and in the books that we give, we offer a lot of resources for the type 1 diabetic, unfortunately not so much for the type 2. The thing that we try to teach when we come in the room are survival skills. What does this child need to go home, or the parent need to go home and take care of this child until they can get them back to the doctor or go to outpatient education? We do teach the meter, how to use the meter, target ranges, when to test. We teach them food groups, carb recognition, carb counting, carb ratio, meal planning, how to handle snacks, insulin types, and how to administer using the vial and the syringe and the pen method in case their insurance change. We also teach hyperglycemia, how to handle that, DKA, ketone testing, teach the rule of 15 with hypo, how to handle the school child and how to handle holidays, and also about exercise and coping with that.
So coping is a big problem, and so as Mary said, we try to make sure they have enough information to make good decisions. So they're never going to feel 100% comfortable because their world is different. Once you've been given a diagnosis of a chronic condition, your world's different. But we want to make sure that they feel like they have control of the situation and they have the support and the equipment that they need to take care of their child safely. So one of the things that we do see a lot of is burnout, and from both the parents and the child's standpoint. And burnout, usually the parent of the child is left with feeling physically and emotionally exhausted. They're negative. They're not engaged. So you usually see a lot of frustration, particularly with teenagers. They're, angry, or they're depressed, withdrawn, hopeless, uninterested in things, and they might have changes of eating pattern. What we see is just this repeat DKA readmission, so the recidivism rate. So recommendations is that they, consult health professionals, attend support groups, rotate caregivers if possible, but we need to make sure that all those family and friends know how to do insulin to carb ratio, give insulin, and they're appropriately trained. Exercise also helps, and healthy eating, and also getting appropriate sleep and rest is important. And also people need to try to maintain hobbies and, physical activity, things outside interest, and not have everything focused on the diabetes. Teenagers, we know, are, extra in terms of parents are trying to make them more independent, turn over more responsibilities to the teen. And some teens are ready for it, and some teens actually rebel. And unfortunately, we see a lot of casualties with diabetes, and it's very sad. But we want to do everything within possible to keep these children safe and to prevent this from happening. Was there a comment? Okay.
Transitioning to from teen to adult, I don't know if you can see this little cartoon. It's blurred. Don't call me a teenager from now on. Call me a pre-adult. Whenever I'm teaching children and their parents, I say you must lead them in the way that they must go. In other words, we want the parents to teach the children how to care for their diabetes, but they can't be responsible for their diabetes. But it is important that 1 to 2 years before transitioning, before this child is turned over to an adult endocrinologist, that the family start preparing for it and start having those conversations about it. 6 to 12 months, we want them to start thinking about insurance, will the child be covered under my insurance? Are they going to college? Will they need to reapply for their Medicaid benefits and things like that? 6 to 12 months. Also, we want to encourage them to review their health status and all that's going on with them before then. Also, we want them to talk a little bit about those risky behaviors. Around the last few visits, we want them to follow up with that insurance, start seeing how much the insulin is going to cost, where they're going to get it from. We want the parents to teach the children how to call and make appointments and things like that, just guiding them towards being independent. The other thing that might be important at this stage is to get them in to see a diabetes educator in an outpatient setting. Once again, some of these children, the parents have been taking care of the diabetes, and these children are fixing to go off to college and might could use a refresher course. The inpatient diabetes educators are here Monday through Friday from 8 to 5. On the weekends, we're on call for newly diagnosed children with diabetes. So if you have a child come in, you need to call the 434-2872 number and leave a message. We do not always see consults. Some of us cannot access the list from home. And so if you leave a message, we will get it. We have those hours because we believe that if they come in afternoon, that especially if they're in the PICU, they'll be here Monday and we'll complete the teaching then. The education usually takes 4 to 8 hours, but with some people, depending on their level and their knowledge, it may take 2 to 3 days. When working with DSS, it can take sometimes a week to get a foster parent. We do have the Children's Hospital newly diagnosed diabetes sheet in ad hoc, where we add what we believe the pharmacy, their insurance will pay for. It's important to get a concierge pharmacy involved.
So at this point, Mary and I will conclude, but we are here for questions. And are there any questions? If there are no questions, we'll turn it back over to Dr. Carney and to Whitney Aubrey.
Really good. Thank y'all.
All right. And I will stop the screen share.
All right, thanks guys so much. I think that was really helpful for everybody to hear and go through for you guys. And hopefully that puts a good kind of bow on this week of glucose metabolism and glucose issues. I guess it's pretty sweet to be done with that. So at this point, everybody can log off if you feel like it. For the interns, if you guys want to stick around, we can catch up and check in on each other, see what's going on in your lives. But otherwise, we'll talk to everybody soon. Thanks, guys.
Okay, thank y'all for the opportunity.
To the Fort Mill location.
This is Lauren. I don't really have anything to say, so
Yeah, I'm sure you have something.
I was just letting you know.
That's fine. That's fine.
Good.
No, that's fine. Are you doing okay, Lauren? Just being there? And I know things got upended a lot for you this week. Is everything going okay?
Yeah, no, we're doing good. So
She's
Oh.
killing it.
I don't have a video on my computers or the video option on this computer, so you can't see me, but we're doing good.
Good.
Yeah.
Well, I know Dr. Gibson's there for you guys, and I had no doubt y'all would kill it. But
Yeah, she helps out a lot, which makes it a
Yeah.
lot easier. So
yep, that's awesome. Good. Zio, you doing okay? I see you on there.
well.
Well,
Sorry.
uh-huh.
Yeah. I couldn't figure out how to unmute for about 12 seconds.
That's okay. That's all right. We've
Right,
had so many
No.
applicants that have like not known how to unmute themselves during the interview cycle or had their stuff go crazy wrong. So that's all right.
Kelsey and I were completely muted for a little bit during the interview the other day. We just forgot.
Oh yeah,
It's
Nitro's
Ashley
here
and
with
I.
me.
There she is. Okay. Where are you guys at?
In the call room.
Oh, in the call room. Y'all didn't go outside to enjoy the nice weather outside today and listen to
I
stuff?
didn't even
So
think of that, and now I'm upset with
smart.
myself.
Yeah, that's why they pay me the mediocre bucks.
I mean, it's more than
I was gonna say it's bigger bucks than that.
It's more than I get.
Oh, yeah, I hope so. If we're on the same pay scale, we're in trouble.
Oh dear. No, but everything's going good.
Good. Dr. Gabriel, how are you?
Oh, it's Dr. Gambro.
Oh,
He's right there. He's very front lit. Hey, Ashley. Alyssa, are you doing okay? Thumbs up? All right. Good. Okay. Well, more than anything, I just want to check in on you guys, make sure everybody's doing okay. And honestly, I think something else I want to tell you guys is just thank you all for coming to the little dinner things that we did together. I really appreciated it and enjoyed them. It was fun for me and Dr. Edwards and Dr. Gray to get some time with you guys in smaller groups to hang out a little bit and just get to spend some time together more than anything else. I just want to say thank you guys for that. Cecilia and Olivia are there too. You guys are just hiding off in the corner, huh? But really, I appreciate that. You guys made the effort to do it. I know it was after hours, and you guys are all exhausted, just from life, but also from stuff going on here. And so to make the effort to do it, because you don't have to, means a lot to me, and I know to Dr. Gray and Dr. Edwards too. So we all really enjoyed it, and we're gonna try to continue to do some things like that from time to time, whenever we have the opportunity to do it, as long as we're not stressing our families out too much by being away too much too. So, but hopefully we'll be able to do some more stuff with that. All right. Oh, Chelsea's joined us too. Hey, Chelsea.
Hi.
How are you?
I'm doing good. Just hanging in here with Emma.
Okay.
And Hemonk.
And Hemonk. Yeah, how's Hemonk
Yep.
going?
Going good.
You can be honest.
I mean, it's fine.
Fine, yeah. I know it's fine.
I'm
means.
fine.
I'm fine. Everything's fine. It's fine.
Yeah, pretty much.
Yeah, you're making do.
Emma's pretty hard to work with, so.
She's very hard to
Well,
work with.
Yeah, I
She's very mean and demanding.
get it. I imagine she's probably got like something to your back right now, making you say that, right?
Yeah, she does.
Oh, goodness. Hey, Scott, how are you? Good. So one other thing I was going to say to you guys is if you guys see or hear that we're going to be having any of the applicants from your home schools or anything like that, and you feel like you want to reach out to them or and you don't get the opportunity to come and do like the interview stuff, because I know life's hectic and you want to, don't feel like you have to at all. You want to reach out to people, just let us know. Okay. And we'll get you contact information just to say, hey, if you have any questions, anything like that. If you feel like you have some sort of personal connection with them, even like when we do those applicant review things, Just let us know if there's anybody you guys feel like you want to talk to or anything like that. And there are times where we might reach out to you guys too. Like if we have people that are from certain parts of the country or that like have kids or something like that. Like Scott, there was a guy yesterday who had some young kids and he was asking some questions. I said, well, he'd be a perfect person to ask just because not only is it weird coming into a place bringing your kids, but during COVID, like what's that even like too? So we might reach out to you guys from time to time about that. And if you don't feel comfortable with it or you don't want to, that's fine too. It is not a necessary required thing. We just like to give people the opportunity to make some connections since they're going to be the people you guys are with for a couple of years. And we want you guys to get to know them obviously too. So, okay. This is the awkward part where we stare at each other. Is that where we're at right now? Just the awkward staring phase of this? Okay, cool.
It was more awkward.
It's only
What?
awkward if you make it awkward.
Okay, I can make it awkward.
You're doing great.
Thanks. I've been practicing. You should see it during interview days sometimes when people run out of stuff to talk about. It's like I'm watching out of my window, people driving and like nearly getting into car accidents and people yelling at each other. And it's actually quite a fun thing to watch out my window, but to not say anything sometimes it's kind of hard. But anyway, all right. Well, I'm gonna let y'all go then. I honestly just, this time is meant to check in on you guys, see how you're doing, see if there's anything. Dr. Edwards has come to me and talked to me about some things that a couple of you guys have brought up. And we'll talk to some people about those things and just issues that have arisen. But one thing you guys will see coming is evaluations too. So we'll start going through our first round of evaluations. And it'll be like 20 minutes of kind of talking through the process for you guys. I know it's a little bit strange to get all this stuff sent to you ahead of time to look at, but it's really meant for you guys to kind of have an idea of what we might be talking about during that time and not be caught off guard. So that's why we send literally everything to you guys to be able to review ahead of time. And so we'll talk more about kind of what the documentation requirements are and all that kind of stuff as we go through stuff. But everybody's doing great. I've gone through about almost all of you guys. Look around the room here. Yep, almost all of you guys' evaluations at this point. A few of them still to go. But everybody, y'all are doing great. The faculty, honestly, their comments to me, not just in the evaluations, but on kind of off the record type of stuff, or that you guys are doing everything in stride and doing great jobs. So keep up the good work. I know sometimes it probably doesn't feel like it because you're so isolated from each other and people probably don't give you that feedback enough. That y'all are doing a good job taking care of people and taking care of each other too. So keep up the good work. And I know it's hard and stressful to be going through all this stuff, but I wouldn't ask for a better group of people to be doing it with right now, to be honest. Keep up good work. Okay, guys. All right. I'm gonna let y'all go so I can get back to evaluations, which I'm so excited about. And if you haven't gotten your new pullover or fleece, they're very nice. Hopefully everybody gets them soon. Oh yeah, there we go. Represent, right? Represent.
Extra's wearing hers too. She said y'all match. Woohoo!
Oh, and that's so sweet. The sweetest thing I ever did here.
Suck up.
All right, well, everybody enjoy the Ohio State football game tomorrow. It's at noon, so don't make any plans. Cecilia, I know where you'll be.
Okay.
But don't worry about doing anything else. Just relax, watch some good football.
So I can get the excuse from work then?
Sure.
Yeah, I'm on
Yeah.
board. So does that mean I don't have to go?
Yeah, go for it. See what happens.
Okay, sounds good.
Yeah, see what happens. If you guys want me to stick around, I would do that. Or don't want me to stick around, I'd do that because Dr. Taylor may be coming for me if you guys all don't show up for work all of a sudden. So a mutiny is a good way to get rid of me. If you guys want to mutinize, go for it. I don't know who's going to jump in, but be careful what you wish for, right? So anyway, enjoy your weekends if you guys have some time off. Hopefully you guys are going to get away from here a little bit from Thanksgiving. And if you're not, if you need a place to go and you feel safe about it, we're always happy to host people over at our house too for things. So if anybody needs somewhere to be for Thanksgiving, if you're off, let me know. Okay. You don't have to do it alone. And I want you guys to feel safe too. So don't feel like you have to come. But we're not going to do anything big or major. But we'll have some stuff at our house too. So if people want to come, you guys are always welcome at our house. You're gonna have to deal with a bunch of princess crap because it is in full bloom right now. After our 3-year-old's birthday this week, it's, oh my God, it's too much. We now have a cardboard Cinderella carriage at our house. That tells you where things are at for us. So it's pretty cool. Yeah. All right, guys. Well, have a good day. Let me know if you guys need anything. Okay. We'll see you guys soon. Thanks, y'all.
Sounds good. Bye.
Bye.
Bye.